Good morning, and thank you for joining us today. We are thrilled to host our third annual Fight and Heal, Pink and Teal, a look at breast and ovarian cancer. Joining us today is a panel of Miami Cancer Institute's experts. A Q&A session will take place following the presentation. We encourage you to use the chat function to submit questions to our panelists. And without further ado, please join me in welcoming Dr. Leonard Kalman, Executive Deputy Director and Chief Medical Officer of Miami Cancer Institute.
Good morning again. Sorry for the technical Zoom difficulties. Next slide, please. Just wanted to wish everyone a welcome from Miami Cancer Institute, from Dr. Michael Zinner, our founding Executive Director and CEO, from me, Dr. Leonard Kalman, our Executive Deputy Director and CMO, and from Michelle Ryder, our COO and Chief Nursing Officer. And again, Miami Cancer Institute has a goal to be on the national stage by year 5. And I think already we're well on our way. We're 3.5 years in and well on our way to that goal. I think at this point in time, we're already the equal of any cancer center in the state of Florida in terms of our clinical expertise, in terms of our technology, in terms of radiation equipment, skin cancer equipment, our surgical innovation, and our clinical trials innovation. And I think our patient experience is second to none. We spend a lot of time on making sure that our staff show a tremendous amount of caring and compassion for patients, and also that our patients can have access to our providers. And I'll let the other speakers speak more about the wonderful things happening at MCI. Next slide. My goal is to talk a little bit about navigating cancer care through the COVID period. So I need to give you a couple of facts. First of all, there really are, the COVID era is still very short. It's been a very small period of time. So any data sets pertinent to cancer are still very small, and the follow-up is very short. So any generalizations I make are based on the best data to this point, but I'm sure there'll be more insights as time goes on and more time passes. The first question, are cancer patients more likely to become infected with COVID-19? The answer is possibly, minimally so, only minimally so, and it's not clear what type of cancer is more likely to become infected. And very important, being on chemotherapy alone does not seem to be an independent risk factor. Now, if you have cancer and you become infected with COVID, which scenarios might lead to a higher incidence of severe or critical events like being admitted to the hospital, like being admitted to the ICU, and God forbid, dying of COVID? Well, not just cancer itself for certain. That itself does not mean that if you have cancer and you're infected, you're going to have a bad outcome. And successfully treated patients with no evidence of disease you do not seem to have a more severe course at all. Now, probably the worst case scenario would be that you have active cancer, you have active COVID, and you need to be intubated and have surgery. That should only occur in the most severe circumstances when surgery is life-threatening. But it has been known from the beginning in China that probably patients with lung cancer, if you become infected, may have a slightly increased risk of having a worse outcome. It's also true of people with hematologic malignancies like lymphoma or leukemia or multiple myeloma, and you're treated with chemotherapy. TKIs, when we talk about chemotherapy, really now when people get medicines for cancer in their body, either intravenously or injected in any other way, there's really 3 classes of drugs. There's a class of chemotherapy, but now there's immunotherapy and so-called targeted therapies. You may hear about some of that later. And the TKIs that I mentioned here, tyrosine kinase inhibitors, are targeted therapies. And there's some data to suggest that if you're treated with a TKI, that you may have a more severe course of COVID should you have cancer. Also, if from your prior cancer, before you get COVID, you have baseline neutropenia, that is, you're more susceptible to bacterial infections, that sometimes can be a secondary complication of COVID. Or if you have baseline lymphopenia, a decrease in your lymphocytes, which obviously are very important in the immune system, you may end up with a more severe course of COVID. Next slide, please. Next slide. Now, should cancer treatments be delayed? Well, first of all, refer to the facts. No. The advanced one, yeah. Refer to the facts above, and you have to look at other things to determine whether treatment should be continued and what's the risk of treating the cancer versus delaying the treatment. And I think you have to take into consideration now that the epidemic is not going to be over soon. Obviously, previously in the first surge, it was felt that perhaps the country would have an organized approach with contact tracing, with mask wearing, et cetera. And that just hasn't happened. So I think we're all in for a long period of this epidemic. And so ultimately, when a decision has to be made about starting cancer treatment or not starting it, or having been treated and interrupted, you really have to make an educated decision between the physician and the patient. But I think everyone would agree that now, compared to several months ago when COVID first arrived, that our bias is to treat, unless there's really a compelling reason not to. And that's a lot different than earlier this year. Earlier this year in the first surge, everyone said, let's wait, let's delay, let's hope again that mask wearing, social distancing, contact tracing, better testing, none of which has occurred in an organized fashion from our federal government, all that would abate the epidemic. That's not happened yet, and it's not going to happen for a while, if at all. So again, I think the bias is to treat unless there's a compelling medical reason not to. Next slide. So I think the biggest risk really when we talk about cancer and COVID is the following. The pandemic could actually reverse a decades-long downward trend in cancer mortality. Currently now about 600,000 patients a year die from cancer. There's been a basically 1% decrease in cancer mortality dating back to 1991. And the reasons are the following. If you do a routine colonoscopy and remove a polyp, you reduce the mortality from colorectal cancer by 50%. If you do routine mammograms, you're going to delay the risk of dying of breast cancer by 41% over 10 years. And there's a 25% reduction, as you can see, in developing advanced breast cancer, which is much more difficult to treat and much less likely to be cured than early breast cancer. And you can see what screening does in terms of cervical cancer. Next slide, please. And as of June of this year, you can see that for breast, cervical, and colon cancer screenings, they're still down somewhere between 25 and 35% or higher. And it's generally known that there's about 40% fewer new cancer patients that have appeared over the last number of months. So those cancer patients are not going to never appear. They're not going away. Unfortunately, what's going to happen is these cancers are going to occur later, and therefore they'll be potentially more difficult to treat. And if you look at that last bullet point, some predict that there'll be in excess of 10,000 deaths over the next decade just to the delay in diagnosis. So that's really the current biggest risk, if you will, of COVID and cancer, that people are not going to go to their PCP, not going to get their first exam, not going to be sent for the routine screenings. Next slide. So we have to ensure that patients, obviously reticent, we're all reticent, 200,000 Americans have died, to go anywhere outside of your homes and anywhere we might be exposed to other people. And yet it's our obligation to make people feel safe so they can have their screenings and have their cancer treatment uninterrupted. And so if we do not do that, obviously, then there's going to be, again, as he said, more patients having delayed diagnosis and ultimately poor outcomes. Next slide. So all across Baptist Health, and especially at Miami Cancer Institute, particularly, we've taken and continue to take this responsibility very seriously. We never did halt or close our operations, but very early on, we reduced the entry points to the building. We have complete control over those entry points. We limit visitors and continue to do so. And we extensively screen every patient and every employee and every visitor each time they enter the building, even if they enter multiple times during the day. Next slide. And if a staff member or a visitor fails what we call primary screening, we direct them to an isolated area, secondary screening done by a very talented and educated group of advanced practice providers, and they do further questioning. And if necessary, we test patients, and we do our own testing in-house. And after that, we have very strict workflows, as my colleagues know, for those who are proven to be positive or under investigation in quarantine and return to work guidelines that follow CDC and other authoritative source guidelines. And we also have done extensive contact tracing of each and every positive staff member or patient because we have control over our environment. And again, masking and social distancing has become mandatory, and monitoring of break rooms and staff eating areas where people might relax and take their mask off to eat or chat. We monitor them and do not allow those things to happen. Next slide. And I'm happy to report that it's all working at MCI. MCI is a safe place for cancer screening and cancer care. Of the 1,600 employees that we have, only 92, less than 6% have tested positive, of which only 25, so that's 1.5% of all the employees acquired infection in the workplace. And remarkably, of the 20,917 unique patients that have traversed through our building from March 1st through September 1st, only 55, 0.26%, have tested positive, and we've contact traced all of them, and none of them have acquired infection in this building. So a patient can feel comfortable and safe that they get their screening and care, they're not going to get COVID in this building. Next slide. So my final point, I close with MCI can be trusted. We've earned that trust. You've seen the data. We will continue to be vigilant for the foreseeable future. We had a meeting yesterday with the chiefs, and we said, let's not let up at all in terms of the things we're doing to keep this building safe. So my message to all of you is, and please tell your friends and relatives, do not forego your cancer screenings. Patients with cancer can be safely treated and screened at our facility. We're going to keep you safe. We'll do your necessary screenings, and we'll continue to deliver state-of-the-art care. Next slide. So I thank you for your time. I look forward to your questions later. Thank you very much.
Thank you, Dr. Kalman. That was, I really appreciate you being here and introducing this program. As you know, the Rock and Run event and the Fight and Heal Teal has been a special initiative, and I've been very proud to be a part of that. I've also been very proud to work with Dr. Mautner, and so happy that you could introduce this. COVID was such an important part of our lives this year, and I will share with you that when this all started, I think we all felt coming to MCI was a safe haven for us, and that's due to all the efforts that you all put in place early on, so thank you for that. So I was going to focus on ovarian cancer. Obviously, this is what the community event is all about, both breast and ovarian cancer and raising awareness. This photograph is taken from right in front of MCI. This was last month. These are the Black Daggers. It's a U.S. Army Special Ops parachute division that came specifically to MCI to honor our efforts here at Baptist Health and at MCI, and to honor the victims of COVID. So we felt very proud to have them, and this was a nice team photograph. Next slide. This is the group of G1 oncologists currently here at MCI, and when it comes to a diagnosis of ovarian cancer, you really want to find the right team. Data shows that women diagnosed with ovarian cancer live longer when treated by specialists, and the G1 oncologist will really quarterback the options and find the best treatment strategy for each patient. Next slide. As I mentioned, we're very fortunate and proud to have two members, specialists who have joined the G1 oncology efforts. Dr. Nicole Eisler, who will be speaking later, specializing in the systemic therapies for treating ovarian cancer, and Dr. Contreras, who focuses in radiation oncology. Next slide, please. Thank you. So when it comes to a strategy for treating most diseases, including ovarian cancer, you can think of it as a stool, a three-legged stool. There's the prevention strategy, there's screening, and there's treatment. Prevention is key. Obviously, that's what we all want, and a lot of efforts are being made in the world of ovarian cancer, currently mostly focused on genetics. And I think part of having a community event such as this one is to remind everyone to look at their own family history, to identify any potential family members who may be at risk, and to understand your genetics. In the world of ovarian cancer, not only can genetics prevent ovarian cancer, but it can also guide treatments. Surgery remains the mainstay of treatment. We have recently introduced something called HIPEC, which is a heated intraperitoneal chemotherapy. And we have found that some women, when introduced at the right time, may benefit greatly and actually live longer without disease when receiving chemotherapy at the time of surgery. Other therapies, as Dr. Kaplan mentioned, we're starting getting away from the term of chemotherapy and categorizing most of these therapies as systemic therapies. There's a whole lot of them, and I think Dr. Eisler will speak to this in more detail. You may have heard or be familiar with something called PARP inhibitors. This has really been groundbreaking for women with ovarian cancer in helping them live longer without disease. And this is a treatment, it's an oral therapy. So basically it's pills that are taken after completing therapy to prevent a recurrence. Next slide, please. As part of our routine here at MCI, and all of the disease sites do this same thing, which is a multidisciplinary tumor board. And you can see there are several of us around a table. It's a conference room. Right now we're doing this by Zoom, where we will evaluate each patient, each new patient, and patients that are possibly needing treatment changes to review with pathologists, radiologists, radiation oncologists, and specialists to come together on a multidisciplinary treatment plan. Next slide. Community involvement is important. It's been something that I've been passionate about, and I know Dr. Montner is, and thankfully Dr. Kalman and MCI have been very supportive of this. This is just an example of our most recent efforts this year to be involved in community publications, information, blogs, and even a textbook that was just published by MCI this year called Breast Cancer and Gynecologic Cancer Rehabilitation. Next slide, please. I'm proud to say that we've just opened our first robotics simulation lab. This is at South Miami Hospital. This is for all robotic surgeons throughout the entire health system, where they can come and train on procedure-specific procedures that are simulated. So this is not on, this is before they actually get to the operating room. You can actually come here and train, be monitored, and work with experts within a simulation lab. Next slide, please. And research. So, a lot of the goals of the current initiative, the Rock and Run, are to raise money for research. And this is what furthers advancement in cancer care. So this is a protocol that we developed this past year, looking at a fairly unusual but very important occurrence of brain metastases in women with ovarian cancer, and how PARP inhibition therapy can benefit these women. I'm happy to say they are doing very, very well, and we look forward to submitting this publication this year. Next slide. Dr. John Diaz, who is the head of clinical research for G1 Oncology, has been extremely active within MCI in bringing in new protocols for us. He received a Biomedical Research Award for bringing a cervical cancer trial, which just opened this week. Next slide. This is an example of what we review in our tumor board, where we look at all of the active protocols that are available here at MCI that we can then see if our patients are candidate for, and then discuss with them as options in their care. Next slide, please. And this is a website called clinicaltrials.gov. If anyone is interested, this is an example of where one could find clinical trials happening here at MCI, and where all of our gynecological oncology trials live, and you can find through this website. And then finally, we have actually not just phase 2 and 3 trials, but a phase 1 trial, which means that these are really the early stages of investigation. We have specialists here on the front line looking at ovarian cancer in phase 1 trials, and very happy to see that this opened this past year as well. Next slide. Finally, as we know, it takes a village. Recently, Miami Cancer Institute was voted a top 3 best cancer hospital in South Florida by U.S. News and World Report. In my mind, yes, this is a lot to do with patient care and research, but mostly it's everything else that goes along with taking care of people. And I think MCI has done such a wonderful job at this, whether it comes to patient scheduling, intake nurses, patient navigation, survivorship, all of our medical assistants, our advanced practice providers, our surgical scheduling, our infusion specialists, and our pharmacy. Everyone works really well together as a team to take care of each one of our patients that come to see us. Thank you. And with that, I want to turn over the presentation to Dr. Star Montner. Star has become a good friend and colleague, and so happy that she's joined me in this effort to reach out to the community and work with Amy Holub in the Rock and Run. And I'll turn over to Star.
Good morning. Thank you for that introduction, Nick, and thank you for having me as a part of the Fight and Heal Pink and Teal Rock and Run lecture series this year. It was an honor to be a part of this last year, and I think even despite COVID, it's going to be even more successful this year. There's already 61 participants on the call, and many people have registered for the Rock and Run this weekend. I want to thank Amy Holub for starting this initiative many years ago now. And because of her efforts and her story and what she went through with her diagnosis of ovarian cancer and then finding out about carrying a genetic mutation, she was able to bring a lot of awareness to our community. And through that awareness also raise many funds that are given back to local research efforts. And so without her, we would not have this lecture series today. And without Nick, we may not have her. And so we owe a lot to Dr. Lambro and to Amy Holub. It's an honor to be part of this once more. Nick gave us a very nice presentation about an overview about the treatment of ovarian cancer and preventing it and treating it and what we have to look forward to in terms of research. When it comes to breast cancer care, there are a lot of similarities between the treatment of breast cancer and ovarian cancer. Number one, both diseases affect women primarily. And secondly, it's a disease of women who are aging, so more commonly in older populations of women. And lastly, genetics play a very key component to both diseases, not only family history, but through genetic mutations, the BRCA1 and BRCA2 mutations. Through those modalities, we also treat our patients with a multidisciplinary approach using surgery as the primary treatment for breast cancer, but also lean heavily on our radiation oncology colleagues and medical oncologists for the treatment of breast cancer. One stark difference between breast cancer and ovarian cancer is that we have very specific and successful screening tools that we can use to screen for breast cancer and catch breast cancer at its earliest stages. And so part of the reason why we've been so successful in lowering the mortality rates from breast cancer is due to screening. And that is with screening mammograms performed annually for average risk women. And then in those women that are considered higher risk, we add on MRI and screen them more frequently. We also like to be able to do prevention for breast cancer. And part of that, there are preventative surgeries and medications that can be given for patients that are at higher risk for developing breast cancer. But I just want to reiterate once more the point that Dr. Kalman made earlier in the presentation, or if you're just tuning in now, is that we've made such strides in treating breast cancer and lowering the mortality from breast cancer that we are starting to see a trend of some of those advancements being at risk in terms of COVID-19 and women delaying screenings and not going for their screenings. A recent report showed a decline of over 85% at some hospitals in screening tests due to the COVID-19 pandemic, and that will undoubtedly lead to several thousands of deaths in the future due to preventable disease such as colon cancer and breast cancer. And so I want to reiterate once more, it's October 1st. It's the beginning of Breast Cancer Awareness Month. And while it seems like common sense to us that women should be getting their screening mammograms, there are so many women that will make an excuse, especially due to COVID-19, that they are not going to get their mammogram this year. And we really want to stop that from happening. I think through events such as the Rock and Run, we can continue to raise awareness and make sure that all of the progress that has been done up to this point does not get reversed. Unfortunately, Dr. Jessica Contreras is not here to give her presentation, but we are going to hear from Dr. Eisler. I just want to touch on some of the points that I'm sure Dr. Contreras would have made. When it comes to the treatment of breast cancer, I'm a breast surgical oncologist, and we have a great team of surgeons here, and we are usually the primary point people in seeing patients that are diagnosed with breast cancer, and usually the first step in treating that cancer is surgery. However, after surgery, many of our patients do require radiation. And part of what is so unique about the Miami Cancer Institute is our radiation oncology department. As many of you know, we are one of the only centers in the country to offer proton beam radiation therapy. And not only proton beam radiation therapy, but all radiation therapies under one roof, and one of the only centers in the world that can boast about that, of having every single tool in terms of radiation treatment under one roof for our patients. Not only does that ensure that our patients get the top-notch care that they deserve, but it also makes the treatment more seamless for them, that they can come to one center and receive all of their treatment under one roof and don't have to drive around and create a stressful situation while they are undergoing their cancer treatment. Proton beam radiation is very interesting at this point for the treatment of breast cancer because it allows us to target the tissue that's intended for treatment and avoid some of the scatter to the heart and lungs. And so for certain patients, they can really benefit from this type of treatment. And so that has attracted a lot of patients to come to Miami Cancer Institute along with our other radiation oncology modalities. And since we've gotten so good at treating breast cancer and curing breast cancer in many cases, now a lot of the studies and treatments that we're looking at are to decrease the morbidity of our treatments. We've been able to decrease mortality, and now we're looking at decreasing morbidity. So one project that Jessica is working on that we may hear more about in the future is shortening the time interval of radiation therapy for patients that are eligible for it. And I look forward to hearing more about that. We're really just getting started in terms of our clinical trials from breast surgical oncology, but we do have many trials open from breast medical oncology that can be found at the same site that Nick had listed. And I really feel that we're able to offer the best care in South Florida for our cancer patients here, and that's due to our amazing team. And so without further ado, I'm looking forward to hearing from Dr. Eisler and what she has to tell us about treatment of breast and ovarian cancer from the medical oncology perspective.
Thank you so much for inviting me. This is a really cool opportunity. I also can't believe we have so many participants. Awesome. So I'm just going to talk about ovarian cancer, sort of in a general sense, but I'm a medical oncologist. I'm not a surgeon. I work very closely with gyn-onc surgeons, also with Dr. Contreras, planning systemic therapy along with how it relates to the patient's surgery. And then not so much in ovarian cancer, there's not exactly a role for radiation, but I do share a lot of patients with Dr. Contreras who are being treated for endometrial and cervical cancer. We can go ahead and move on to the next slide. So the goals of my short talk are to discuss symptoms, risk factors for ovarian cancer, germline testing. That means germline testing just means any gene that you could have inherited from your parents. Now, the reason I'm spelling that out is because we also do tumor testing. I'm going to talk about that as well. We're going to talk about prevention for patients at increased risk, personalized therapy, and then sort of where we're headed for future options for treating ovarian cancer. We can move on to the next slide. So I encourage everyone to check out this hashtag campaign, I wish I knew. We can go to the next slide, but it's many quotes that you can look up under hashtag I wish I knew, and it's patients mentioning, little tidbits that they've learned through their diagnosis of cancer. So symptoms. The problem with symptoms of ovarian cancer is that they're nonspecific. So many patients end up in the clinic and they say, I thought I had a urinary tract infection, or I thought I ate something bad. Meanwhile, they've had bloating for several weeks and their ankles are swollen. That is never normal. The main thing with symptoms, and patients may have none of these symptoms that you see on the slide or all of them. The main thing with symptoms is that they should abate. If you're having ongoing swelling or you're not tolerating your meals and it's lasting even over a week, you need to see your primary care doctor, but in particular, you need to see your gynecologist. The gynecologist processes information about discomfort related to urinary stream, related to the abdomen, pelvis differently than your primary care doctor. And you'll also get an exam. So that's sort of the gold standard. If you don't feel well, if you're having some of these symptoms, it's not just your primary care doctor, you need to see a gynecologist. We can move on to the next slide. Another, I wish I knew. I cannot tell you how many times I've heard this statement. I get a patient who already has an ovarian cancer diagnosis in my office, and they tell me they have two sisters with breast cancer and one brother with pancreatic cancer, and the sisters with breast cancer were under 50 years old. So that, in theory, should raise a red flag. If patients are well informed, if the community is well informed, that maybe you should head for genetic testing if this is happening to your relatives. We can go on to the next slide. So risk factors. Obviously, the incidence of all cancers increases with age. That relates to your genetics. As we age, the genome sort of becomes more unstable. In ovarian cancer in particular, the rates are higher postmenopausal and much higher in the geriatric population. Ashkenazi Jewish Ashkenazi Jewish population does have a higher rate of ovarian cancer because they harbor a higher rate of the BRCA mutation. Not having children is also a risk factor. So the slide's kind of busy with my arrows, a little comment I made to the right here. I wanted to mention those risk factors, but also I want to harp on family history. A lot of people think out in the general population that it's only breast, ovarian, or endometrial that really matter as far as your family history. You actually need to know your whole family cancer history, and I mean everyone. You should write it down and carry it with you like your list of medications. It's that important because there are patterns related to certain types of tumors that not everyone will pick up on, including primary care physicians. So we can move on to the next slide. We're talking about family history in particular. I named a few other risk factors. I listed 3 diseases right here: pancreatic cancer, melanoma, and prostate cancer, because those diseases as well are related to the BRCA mutation, and very few people know that. Again, I'm just trying to make a point for the general population. You need to know about any tumor that has occurred in your family, because it's not just going to be breast and ovarian that spark your primary care doctor or your gynecologist to send you for genetic testing. Any of them can matter. The male history of cancer is equally as important to the female history of cancer. In particular, I would like to say if you are related to anyone with a history of male breast cancer, you may need genetic testing. We can move on. So I'm sorry, I'm having a throat problem. So a sort of a crazy looking slide Venn diagram, but let's just focus on what we know. Everyone knows about the BRCA mutation, but the fact is there are many other mutations that result in cancer. So let's just look at BRCA listed there in the middle. You see there are 3 types of tumors overlapping there. I can't tell you how many times I've seen this. You can have someone show up in your office with a new ovarian cancer diagnosis and they have a relative or 2 relatives with breast cancer, another with pancreatic cancer, or perhaps someone with prostate cancer, but it's sort of been ignored because there were males involved in its pancreas and its prostate, but they're actually all interconnected. Many other mutations are listed here related to genetic syndromes. Can we move to the next slide? So we're going to talk about genetic testing a little bit. If you have this family history or if you have a personal history, you probably need genetic testing. The first person you should start to talk to this about is your primary care doctor. They actually can send a genetic test. They can. The problem with that, though, is that they don't always know how to interpret or give you advice on that testing. You know, we're talking about the general population here, not anyone who has necessarily had a cancer diagnosis. I just included these 2 pictures because some people don't like to have a lot of blood drawn. Part of the genetic testing, or one way that you can get a sample, is by spitting into a tube. Another is blood, and we actually do both here. So genetic counseling, we can move on to the next slide. Who gets genetic testing? All patients with ovarian cancer, okay. Straightforward, easy enough. It has implications for the treatment that they can take. I'm going to talk more about that. Dr. Lambert touched upon it. Also has implications for their family members. The ASCO guideline is that if one of our patients has a mutation that helps them get ovarian cancer, their 1st and 2nd degree relatives need to be tested as well. Here at Miami Cancer Institute, where we have the most sophisticated genetics team I have ever encountered, and that is compared to New York, where I worked as well. Just such an excellent team. It's a large team. It's the biggest genetics team I've ever worked with. They can go down your family history in such detail, in better detail than I can. And then when they get that testing result, they know how to sort of guide you as far as screening what doctor to refer you to, okay? Well, our genetics team actually includes 3rd degree relatives. So that is beyond the ASCO guideline for genetic testing. Ashkenazi Jewish descent, if you are of that descent, you do need genetic testing because of the rate of the BRCA mutation. It's quite high in that population. And then the family history. One of my main goals today is to have everyone who's listening understand, who's out in the community, that it's not just breast, ovarian, and endometrial. It's actually all the tumors in your family that you need to know about. We can move on to the next slide. All right. So this is a really, really, really busy slide. It has the word germline in there. Remember, germline means hereditary from your parents. I just wanted to make a note that it's about 14 to 15% of the high-grade serous ovarian cancer is related to a BRCA mutation. Now that is quite high. But you hear that, or the word BRCA becomes so commonplace in the community, which is a great thing because everyone needs to understand it. And then people end up thinking, like, I got cancer, there must be something like the BRCA gene that caused it. I think it's important to understand that the majority of cancers actually are not from a hereditary mutation. So that is all this slide is showing, that in our patients with high-grade serous ovarian cancer, they actually have many, many, many mutations. It's only about 14 to 15% that are BRCA, but still that's a very large percentage. Think about the benefits of that, of picking up on the fact that you have a mutation that can cause ovarian cancer. You're going to have time to get to the appropriate counseling so that you could get your ovaries removed or go on birth control. We'll talk more about that in just a second. So let's move on to the next slide, please. All right, so it's not just BRCA. When you undergo genetic testing, you actually a large profile of you're screened for a large profile of mutations. These are all sort of different, and the pattern of inheritance is different, and that is where it comes in that you're talking to a genetic counselor who is dealing with these mutations and the patients with these mutations all day long. Now, if your primary care doctor gets that result, they're not necessarily going to be able to navigate all of that with ease. So sort of the point of this slide, we all know our BRCA, BRCA1, BRCA2 are different. The rates of ovarian cancer are different, but there are many other mutations that result in increased lifetime risk of ovarian cancer. So picking up on any of these is a win because you'll have time to be referred to someone like Dr. Lambrewer, one of the team members, one of the gynocs, who can talk to you about risk reduction. Let's move on to the next slide. All right, so this is just a little plug for our genetics team here. I encourage everyone who's watching to go to All Health TV and watch the Q&A with Dr. Martir-Negron. It's excellent. A lot of people carry the wrong idea about genetics in their head, and she clarifies a lot of that stuff. And Jessica is also heavily involved in the management position and is a clinical genetic counselor as well. Let's move on. Next slide. So why do we do all of this? Because you want to catch your risk before you actually have a cancer diagnosis. Use of oral contraceptives in the right population is known to decrease the risk of ovarian cancer. This is a conversation that I recommend having with a gynecologist oncologist, not your PCP. In theory, you could have it with your gynecologist, but the gynecologist oncologist is going to know the facts, the risk versus benefit of something as serious, let's say your past childbearing, of having your ovaries removed. And of any risk that might possibly remain after that surgery. That's why it's important to go to that type of specialist, not just a regular gynecologist. So you find out you have a mutation, you catch it in time, you see a gynecologist, oncologist to talk about oral contraceptives. That could also in theory be your gynecologist, but the gynecologist, oncologist for the surgery. Next slide. All right, so everyone asked about this as well. We have many patients, unfortunately, who get an ovarian cancer diagnosis and they had just had a pelvic exam about a year prior, and they are simply crushed because they've been following all the rules for mammogram, seeing their PCP, getting their blood work, getting their pelvic exams, and they have an ovarian cancer diagnosis. Ovarian cancer is a secret, and it shows itself out of the blue, and there is no good screening. There is no good evidence to routinely do a transvaginal ultrasound or send CA-125, that's the ovarian cancer marker, on patients from the general population unless they harbor one of these mutations that results in increased lifetime risk of ovarian cancer. Why is that? I don't know if we have time for that conversation, but there are many reasons. I don't want to convolute this conversation, but let's say this is rooted in science, and I fully agree with it. I do not think everyone from the general population should be getting tumor markers or a transvaginal ultrasound. It should be if your risk is increased. We can go to the next slide. All right, systemic therapy. So this is my area. I'm a medical oncologist, so I give the chemotherapy, the oral therapy. Pardon me. So again, chemotherapy, now we're much more sophisticated. We have all these different types of therapy that work in different ways, different drug classes. But the mainstay of treatment for ovarian cancer is surgery in conjunction with a chemotherapy. Now, systemic therapy, then I highlighted then because I would like to make a point that the chemotherapy that we use is the same that we were using in the early 90s, and that is still a standard, okay? Good or bad, I don't know, but I wanted to state some years for a point I'm gonna make later on in the talk. So cytotoxic chemotherapy is the type that's non-specific. You know, you take it per an IV, you could lose your hair, it affects all the cells of the body. It's non-specific to the tumor cell. So moving down the timeline, bevacizumab, which is a different drug class, it's actually an antibody, it's a biologic. It has a mechanism of the tumor cannot grow blood vessels to it because the drug sort of grabs on to a molecule that's required for that process to take place. So might sound kind of wordy. I don't know what the audience's complete background is, but what I'm trying to show right here is that different approaches for systemic therapy are required in order to get this disease under control. So 2014 was the approval of one of the first biologics, an antibody, bevacizumab. Platinum-resistant disease was the first approval. Platinum-sensitive is the second approval. If we have time, we can talk about the difference between those two later, but I'm just trying to show the trajectory of drug development for ovarian cancer. Now, PARP inhibitors, a hot topic. Still, though, I'm sort of discovering that even the community does not really know what a PARP inhibitor is yet, but they should. Eventually, the community should know just as much about ovarian cancer as breast cancer. So the first PARP inhibitor was approved for BRCA-mutated patients who had received a lot of therapy in 2014. We can go to the next slide. So just a quick question, what is somatic or tumor testing and how does it relate to what I just talked about and what I'm gonna talk about, which is tailored therapy. Therapy is not one size fits all. All right, somatic or tumor testing is, can you forward so we can have the answer come? All right, it's a molecular sequence of the patient's tumor showing acquired mutations. The results can predict how a patient will respond to certain therapies like PARP inhibitors. Why is this important? Because I already know about you. I know about your genes that you got from your parents. I need to know about the genes of your tumor to know what your tumor is going to respond to and to see what clinical trials you are going to be eligible for. Let's go on to the next slide. All right, so we're talking about genetic testing. We know that all of our patients get genetic testing. That is, what did they inherit? We know all of their tumors get tested. If I don't find anything that they've inherited, I move on to testing their tumor. So how does it incorporate? Let's say we figure out that you have a BRCA mutation and your BRCA is either you got it from your parents or your tumor has one. Well, we've discovered with PARP inhibitors that if you have one of those mutations, the PARP inhibitors actually work a lot better. And I'm going to show you how much better. Even though we do have a broad approval for this drug, if you don't harbor one of these mutations, they work better with patients who have inherited one of the BRCA mutation, for example, because patients with BRCA mutation, they don't keep their DNA nice and pretty and unbroken. So kind of a strange concept is that if there are too many breaks in the DNA, the cell is going to die. Do you want that to happen to an ovarian tumor cell? Yes, you do. So by using a PARP inhibitor, you can take advantage of that break that's already there because you have the BRCA mutation. You inhibit PARP, who's going to try and save the cell, and the cell is automatically funneled towards death. So PARP inhibitors, again, work better in patients who have one of these mutations because it's easier to get the tumor cell to self-destruct. We can move on to the next slide. All right. So solo one, I know we don't generally look at Kaplan-Meier curves in the morning news, but when you're looking at these curves, you want the split to be large. This is one of the biggest successes of the last 10 years as far as drug development for ovarian cancer. If you look at the top line, olaparib was the first approved PARP inhibitor. Look at the difference in percentage of patients free from disease and death. That is significant. This was a success. It is changing the landscape for patients and already has saved tons of patients. This is a big deal. This was just in 2018. If you see here, though, these were all patients who had a germline BRCA mutation. The BRCA is really important for this drug to work, and you don't have to inherit it. It can be in your tumor as well. Can we go to the next slide? All right, so therapy now. Again, we're using the same chemotherapies, but there's this concept of maintenance. Current guideline is that almost all patients should be on maintenance therapy. What is maintenance? It means you finish your chemotherapy and now we're going to keep you on something, either the bevacizumab that I've described, the biologic, or a PARP inhibitor, or both. So how do you decide which one you do? Talking to patients who actually have an ovarian cancer diagnosis, it's a difficult decision. It's a difficult decision. We do know that patients with the BRCA mutation or a BRCA-like mutation, and I listed a few of them earlier in the presentation, actually respond a lot better to that maintenance with a PARP inhibitor. At this time, though, everyone is eligible to go on a PARP inhibitor after they finish chemotherapy. Bevacizumab, the biologic, is also a possibility, and you can do both. Which one you do is a conversation with your doctor, but I want everyone to understand that if you harbor one of those mutations, the PARP inhibitor is going to work better for you. We can go to the next slide. All right, so question. So what is actually happening when a patient has a BRCA mutation? Can you go back? All right. The view changed. I'm almost done. I probably talked too long. Okay. So can we have the answer come up? So what is actually happening when a patient has a BRCA mutation? All right. Patients do not properly repair their DNA. What do we learn, though? That if you use a PARP inhibitor, you can kill your tumor cells better if you have a mutation like this. Next question, can a patient have a BRCA mutation in their tumor if it didn't show up in their genetic testing, what they inherited? Answer, yes. So that's why we test the tumor as well. Question, what therapies have been approved for patients with ovarian cancer and a BRCA mutation that improve overall survival? Answer, PARP inhibitors. Okay, so now everyone who's listening maybe hopefully knows a little bit more about where we're, what we've accomplished and what we're going to do in the future. I have a few slides on that. Can we go to the next slide? I'll try and speed it up. All right, immunotherapy. I have a lot of patients coming into my office and requesting this therapy because the primary investigator who discovered this in his lab, he won the Nobel Prize, and he changed cancer treatment for a lot of people forever, and our survival rates are better in many diseases, including lung, endometrial, renal cell carcinoma. It is one of the biggest events in cancer therapy in the last 50 years. So it is not yet a winner for ovarian cancer unless you have clear cell carcinoma. That is recent data from ESMO 2020, a few days ago. Clear cell carcinoma, there appears there's a benefit. Now, current trials are examining what to combine with immunotherapy so that it works better in serous ovarian cancer. We can go to the next slide. Basically, to make a point, immunotherapy only works if you have the white blood cells near the tumor because it's working on the white blood cells. Basically, immunotherapy is allowing your white blood cells to efficiently attack a tumor. Now, if that tumor is not exactly, it doesn't have a lot of those white blood cells floating around it, how's the therapy going to work? So that's, I put it in like pretty general terms, but that is essentially what needs to happen. So where we're headed with our trials is including a drug that will possibly spark the white blood cells that we need closer to the tumor so that the immunotherapy can work better or more efficiently. We have active trials on that, and there will be more down the line how to sensitize the tumor to immunotherapy. We can go to the next slide. All right, participation in clinical trials. I can't say this enough. It's so important to know what clinical trials are available and if one is right for you, because we would not have any of these developments, such as with PARP inhibitors, unless patients were enrolled on clinical trials. Clinicaltrials.gov is a great resource. Next slide. progress to be made. So this little schematic here, mortality in the blue, survival in the pink. Ovarian cancer has a higher mortality rate than cervix, breast, and uterus cancer. Why is that? We don't have the advantage of good screening like in breast cancer. Our patients are often diagnosed at stage 3 or stage 4. Also, that is a fact, there are fewer treatment options for ovarian cancer. We need more. How are we going to get more? Clinical trial and designing clinical trials that are thought to be efficacious, and then enrolling patients. Next slide. All right, I really like this slide because it proves something that I always knew was true, and I'm not sure if everyone knows. Look at the funding for breast cancer, which is wonderful. Mortality here gets a little confusing. That's the little turquoise bar. Look at the funding for ovarian cancer. This is the regular line. It's much lower than breast cancer. Why? Not as many. Ovarian cancer is more rare than breast cancer, but the mortality is so high. We need more money. We need more money, and we need more drugs, and we need higher survival. This is a study by Northwestern showing mortality and then how much money or funding each of these tumor subtypes has. I think we can do better with ovarian cancer. What is the first step in doing that? Having everyone understand what ovarian cancer is in the community. It's just as important as breast cancer. Next slide, please. Here are some resources for anyone watching. foundationforwomenscancer.org, sgo.org, patient resources if you want to learn more about any of these tumors. All Health TV is an excellent resource that Baptist has. You should watch Dr. Martina Negron's Q&A. It's really good to become an expert on genetics yourself. Next slide. Okay, you can play the movie. Play it. Okay. This is something one of my friends made for ovarian cancer awareness. I liked it. So that's it.
Hi, everyone. My name is Dr. Jessica Contreras, and I'm a radiation oncologist at Miami Cancer Institute. I specialize in the treatment of GYN and breast cancer. So today we will briefly cover an overview of the role of radiation therapy for breast cancer and ovarian cancer. Breast cancer is the most common malignancy in women. It affects approximately 270,000 women every year in the U.S. alone. Although we've made significant improvements in breast cancer screening and treatment, we know that breast cancer is still responsible for the second highest number of deaths across all cancers in women. Now, this is really important because across the U.S., we know that 1 in 8 women will be diagnosed for breast cancer, meaning that all of us women have approximately a 12% risk of being diagnosed with breast cancer. Now, I previously mentioned that we've made significant improvements in the treatment and diagnosis of breast cancer, and this is really because of screening mammograms. So over the last 30 years, we know that broad implementation of screening mammograms have allowed women to be diagnosed at a much earlier stage. When women are diagnosed at an earlier stage, they have less invasive treatment and have much, much better outcomes. Women that are diagnosed with an early stage breast cancer have a 97 to 99% of survival at 5 years. So it's a really important test. The American Cancer Society recommends that women start talking about screening mammograms with their physicians around 40 years of age. At 45, women that have an average risk of normal risk, so your average risk of breast cancer, no higher than the normal population, should start annual screening mammograms at 45 years of age and undergo these annually. Now at 55, these can be spaced out to every 2 years. One thing I will say is that women that have a higher risk of breast cancer, so those that have a strong family history or have a history of receiving radiation at a young age to the chest, may want to discuss these specific risk factors with their physicians to understand if they should start screening mammograms at an earlier age. Now, when a patient is diagnosed with breast cancer, we think about treatment really in 2 ways. We think about the local treatment, so that's the treatment to the breast and the lymph nodes, and then we think about systemic treatment, so treatment that goes everywhere in the body. Systemic treatment is really composed of chemotherapy or anti-hormone therapy. Now, when we think about local treatment, we think more about surgery and radiation because they're really focused in one area. So at diagnosis, women will undergo surgery. Surgery can either be a more limited surgery that conserves the breast, so a lumpectomy. In that surgery, the patient just has the tumor and a surrounding margin removed. or in patients that have more advanced disease, so a larger primary that's involving the skin, among other things, they may undergo a more invasive surgery, so a mastectomy, and this is where the entire breast is removed. During both of these procedures, surgeons will often sample and take out some of the lymph nodes that drain the breast. This is to verify that breast cancer has not spread to these lymph nodes. And after patients undergo surgery, we know that radiation therapy, when indicated, can really decrease the risk of the cancer coming back locally, so in the breast and or regional nodes, by up to 50 to 70%, so a pretty significant number. And in a lot of these women, radiation will also prolong their life. We know that in patients that have early stage breast cancer, giving radiation really prolongs their life. So for every 4 women that we prevent a recurrence, we're really saving 1 life. So there's a local control benefit and an overall survival benefit. Now, Miami Cancer Institute is a very unique place because we have every single type of advanced radiation modality available under one roof. And that's what I'm showing you here. Ultimately, what this allows us to do is it really allows us to tailor treatment for our individual patients. Now, I mentioned that our patients are living longer and they're doing much better. So quality of life is so important for these patients, and also decreasing the amount of side effects that we give these patients. So these modern radiation techniques and machines that you see here really allow us to spare all of the healthy tissue, because we know that radiating normal structures like the heart raises the risk of patients developing heart disease. So we know from thousands of women that were treated with older radiation techniques that treated a larger area or gave higher doses of radiation to the heart, we know that these women unfortunately developed heart disease, including congestive heart failure, arrhythmias, and cardiomyopathies. So here at MCI, we really are careful with every individual patient plan that we create, and we use all of this technology to help us spare normal structures like the heart. So here I will go over a couple of examples of some radiation plans and how we're trying to spare the heart and lungs. So on the screen, what you see is an example of a patient that had a lumpectomy, so a breast-conserving surgery, and required radiation to the whole breast after surgery. So on the right-hand side here, you're looking at a cross-section of the patient's body. And this is what I'm showing you with the arrows. So here in the center, you're looking from the top down. You see the patient's heart, and you see the lung on one side, another lung. And the area that we're treating is here in purple. So it's the breast that I'm outlining with my arrow. Now, the different colors here show different doses of radiation. And what I wanted to show you really is that, as you can see, the purple is my target. So the purple is the breast that I'm trying to that I would like to treat, that we need to treat with radiation. Now, the lines here indicate, what these tell me is that the lung, this part of the lung, and honestly a small portion of the heart here, are getting high doses of radiation. So here at MCI, one way that we prevent this from happening is we actually have patients lie on their belly. So here on the right, patient was lying on their back facing the ceiling. On the left, this patient is receiving exactly the same type of treatment, but now they're laying on their belly. And what you'll notice here is that the breast, in purple again, is now being pulled down by gravity. So it's being pulled far away from the body. And what that's allowing us to do is to treat the breast with radiation. But as you can see here, those same lines of radiation that were going into the lung and even partially the heart are now not touching the lung or the heart. So by putting a patient on their belly, we're able to better spare the heart and lungs, thus decreasing the risk of heart disease. Now, another technique that we can use to treat patients with early stage breast cancer is something called partial breast radiation. And radiation oncologists are not that creative. So partial breast just really means partial breast. So it means we're treating only a small portion of the breast and not the entire breast like you saw in the last slide. But the way we do this is we place this device called a SAVI on your right-hand side into the area where the patient had cancer. So this is where the primary tumor was located. And what this device allows us to do is treat patients with radiation from the inside out. So by treating from the inside out, we're treating much less normal tissue, because as you can see on the screen, we don't even have all of the lungs and heart in the picture, indicating that those tissues are really getting negligible doses of radiation. So partial breast treatment using this internal device, or the SAVI applicator, really allows you to spare normal parts of the breast, lungs, and the heart. Now, in patients that cannot have this device placed, we can also deliver this type of partial breast treatment with external beam radiation, and that's what I have shown here. Again, you have cross sections of a patient in the top row, and these are slices, coronal slices, so taken across the patient. And these lines, ultimately what they're showing you are different doses of radiation. So these are different ways to deliver radiation to the partial breast, but ultimately what this is showing you is, again, as you can see in this picture, instead of treating the whole breast, we're really only treating a small portion of the breast, and we're also better able to spare the lungs and the heart. So treating patients on their belly, so in the prone position, or treating only a smaller portion of breast tissue with partial breast really allows us to decrease the dose to normal structures and ultimately decrease the number of side effects that our patients experience. Now, when patients have more advanced disease, so let's say they had a larger tumor or they had lymph nodes that were involved at the time of surgery, we know that radiation in that setting not only decreases the risk of cancer coming back, but it also improves their overall survival. And this is a picture of a patient. So this is her heart. You see lung on one side, lung on the other. And the area that we're treating now is a lot larger because we have to treat those lymph nodes. And those lymph nodes are located here in the patient's neck, under their clavicle and in the axilla, and behind the breastbone. This radiation treatment plan that you're seeing here uses an older radiation technique, but here at MCI, the way we treat patients that need radiation to the lymph nodes is using proton therapy. So proton therapy is a type of radiation therapy that has the same efficacy as standard X-rays, but one of the major benefits is that it really allows you to spare surrounding tissues. So on the left-hand side here, you see a patient that received treatment with conventional radiation. On the right-hand side, you see someone that received proton therapy. So similar to what we discussed a couple of slides ago, the different colors indicate different doses of radiation. So the red is the high dose, green is a little bit lower dose, and blue is slightly lower than the green. And what you can see on the left, in a patient that had conventional radiation, you see that a significant portion of the heart itself here is getting treated by this dose of radiation in the blue, green, and even a small portion of the red. Similarly, the lungs are getting treated by a larger area, and that's what's shown here as well on a different slice. Now, if we look at the same patient that was planned with proton therapy, we see that with protons, you don't have this blue dose spill that you saw on the left. That really doesn't exist. The dose of radiation is a lot more conformal. You're better sparing the heart and lungs and ultimately decreasing the risk that a patient can have a severe cardiac toxicity and lung toxicity. So next, we'll talk about ovarian cancer and the role of radiation therapy in ovarian cancer. Ovarian cancer is primarily treated surgically and with chemotherapy. Patients often undergo multiple lines of systemic therapy, and now there are different targeted agents that can be used as well. Historically, radiation has always had a limited role in this disease process, but recently there's been emergent evidence that demonstrates that there may be a role for radiation in this specific diagnosis. And the patients that may actually benefit from radiation therapy are those patients that have been on multiple lines of chemotherapy and potentially have only a couple of sites of disease that are not responding to treatment. So when I say a couple of sites, I mean 1 to 5, or patients that really need a chemotherapy break. So these may be patients that have been on chemotherapy for many, many months, are having a lot of side effects and need a couple of weeks or months off of chemotherapy. So it's patients that have these limited sites of disease that are called oligometastatic cancer patients. And all that means is that you really have only a couple of sites of disease as demonstrated here compared to someone that has disease that has gone to more places in the body. So in patients that only have a couple of sites of disease, we know that ablative radiation can help us control the cancer locally and give patients a bit of a break from systemic therapy. Now, these high doses of radiation can carry a higher risk of side effects, because when I say ablative treatment, I really mean that we're giving a full course of radiation that historically used to be delivered across 5 or 6 weeks and only 5 or 6 treatments. So as you can imagine, giving these much, much higher doses per treatment can carry a lot more side effects if we were to deliver this to normal organs. So in patients that have ovarian cancer, we're often treating sites in the belly or pelvis. And one of the problems in those areas is that if you can imagine your stomach, your small bowel, your intestines, they're constantly moving throughout the day as you're eating, drinking. Things are constantly moving and they're never where they were a couple of minutes ago. And that's something that we have to take into account when we're planning these high doses of radiation for treatment. So on the bottom, what I'm showing you is the plan for a patient that was going to receive radiation to a node, to this area of disease here. And this was a screenshot in time. So this is, again, a cross-section of the patient. You have a liver, in blue you have their stomach, and in green you have a kidney. So this was the day that we planned treatment. When the patient came back for treatment, what you can see is that things have shifted significantly, right? Their belly, their stomach was in a different position. It actually had a little bit more gas and it wasn't as full. And what this caused is the volume, the area that we're treated, that we're planning on treating, essentially to deliver that full dose of radiation to the stomach, which is not what you want to do. That would lead to more side effects. So the way that we can do this, the way that we treat patients that require these high doses of radiation to the belly or pelvis is we use MRI guidance. So we have a specific machine called a ViewRay that allows us to deliver radiation treatment with real-time MRI. So the machine, this is a screenshot from one of the treatment plans, gives us a real-time scan. So this is a cross-section of a patient. And what you're seeing is a patient on the table undergoing a real-time MRI. So the patient is taking a deep breath in and out. And what you can see is that everything is moving, right? The target that we're treating is moving out of the area of the high dose. It's moving in and out. The patient stopped right there. But they'll resume their breathing shortly and things will start moving again. The stomach changes. You can see movement in the intestine. So what this machine allows us to do is it allows us to track real-time motion in patients and only turn on the treatment when the area that we want to treat is in the target region. By doing this, we're able to better spare surrounding organs and we're able to give really high doses per treatment to small areas of disease. So this is an excellent treatment for patients with oligometastatic ovarian cancer, so patients that have very limited sites of disease in the belly or abdomen that are not responding to chemotherapy or need a chemotherapy break. Okay, thank you everyone for your time.
I know we have lots of questions that came in, so I thought we could just launch right into them. It's 11:30, and I propose that we go to 11:45 so that we can address the many questions that came in. And I'll just start with the first one because I think it's so relevant to what you touched upon very importantly. It says, Dr. Lambrou, I'm a 58-year-old in menopause, never had children, and have Ashkenazi Jewish heritage. I'm due to have my annual GYN appointment at the end of October. Should I have genetic testing, or is there another exam I can have to rule out ovarian cancer? And does insurance typically cover genetic testing? So this is exactly the person that we hope to reach out to, that yes, you do qualify for genetic testing based on heritage alone. And yes, insurance does cover this. We'd be happy to provide the resources to you to get that testing done if your gynecologist doesn't do so, but this is important that you do get testing.
So one attendee asked the question, is there a correlation between breast cancer and ovarian cancer, and how high is the incidence for a woman that develops breast cancer to then develop ovarian cancer? So the short answer for this is yes, there is a correlation between breast and ovarian cancer, and that correlation usually has to do with genetics and the BRCA1 and BRCA2 genetic mutations. As Dr. Eisler said, these mutations are generally relatively rare. They are more common in Ashkenazi Jewish women. So when we see an Ashkenazi Jewish woman that has either breast or ovarian cancer, that usually does trigger genetic testing. But in general, for patients that come into the office that have breast cancer, only about 1 in 10 will test positive for an actionable genetic mutation. And as Dr. Eisler said, about 14% of women with ovarian cancer will have a BRCA1 or BRCA2 genetic mutation. If you're a woman that carries one of those mutations, then yes, you are at higher risk for developing ovarian cancer if you've had a history of breast, and vice versa. You're at high risk for both breast and ovarian cancer. However, if you do not harbor a genetic mutation, then those women generally are not necessarily at higher risk for ovarian cancer just because they've had breast cancer. If there's family history of ovarian cancer, but yet you don't have a genetic mutation, it's still something that you need to see a gynecologic oncologist about, because there are some genetic mutations that we have not identified yet. And so there is some sort of hereditary component to some of these diseases where we just are not able to identify the gene. There's probably a BRCA3 floating out there, and one day we'll be able to identify that gene. Until that time, it's important, once again, to know your family history. And I also want to stress, because this has to do with Amy Holub and also many other patients that I see, knowing your paternal family history is very important. So even if your mother never had breast or ovarian cancer, or your maternal grandmother never had breast or ovarian cancer, but your father's mother or your father's grandmother had ovarian or breast cancer, that history matters. In some families, there's a very limited paternal history, and it's just one relative that had breast or ovarian cancer. However, that gene could have been passed down to the father's side, and the father could pass it down to subsequent daughters. So even with a very limited family history, you could be at high risk for breast or ovarian cancer. And so genes can be passed down from both your maternal and paternal side. There's a 50% risk of harboring a gene if either your mother or father has that gene. And so that's very, very important to note. And I think that's why it's one of the more important things when you do genetic testing, to really meet with a counselor who can go through the family history thoroughly and talk to you about risk, and not just to necessarily do it at your PCP or gynecologist's office without appropriate counseling.
So we have a few other questions. And Gabby, maybe at the end of this, if we could send to our attendees information regarding our genetic services here, because there are clearly lots of questions that might be answered by our genetics team and possibly set up consultations. Here's a question. I have an aunt who had ovarian and breast cancer. Should I get genetic testing? So if your aunt had both ovarian and breast cancer, I think the answer clearly yes, you should get tested. And then there's an interesting question. Is there any truth, I guess this is mostly for Star and for Nicole, is there any truth that eating moderate to high amounts of unprocessed soy, such as tofu and tempeh, may increase your risk of breast or ovarian cancer?
Yeah, I get this question a lot. I'll let Nicole answer also from her perspective. The short answer is no. Those foods, while they contain very low amounts of plant estrogens, they don't correlate to an increased risk in studies. I wouldn't eat it every single day for every single meal, but that is not a food that you absolutely have to avoid. There are some supplements and vitamins that have very high levels of plant estrogens in them that patients may be taking, and in those cases, we say avoid those supplements. But Nicole, do you have anything to add to that?
I always say soy in moderation. Sometimes I have a vegan who only eats soy products every day, and I do recommend against that because they are estrogenic.
And then one more point about genetic testing. A lot of patients aren't sure if they qualify or if insurance covers it. I believe that a visit with a genetic counselor is covered, and they can help guide you into what's covered in terms of the actual testing itself. So a first stepping stone in getting genetic testing is just meeting with the counselor. And I believe that appointment is always, covered. And then they can talk to you about what the implications of the testing are and what insurance does and does not cover and what type of panel they would recommend for testing for you.
Star, here's a question for you, which is outside of the high risk group, but at what age should someone start routine mammograms?
So the average risk woman, meaning not someone that has an extraordinarily particularly concerning family history for breast cancer, but just the average risk woman should start at the age of 40. That being said, there are guidelines for women that are at higher risk. So let's say your mother was diagnosed with breast cancer at the age of 47. Then we say you start screening 10 years prior at the age of 37. So it's whatever comes first. It's either the youngest relative in your family that had breast cancer, we start screening 10 years prior, or if you've reached the age of 40 and haven't started screening, you start screening at that age. There are many conflicting recommendations throughout the United States, depending on what source you go to. And some of the recommendations say start at age 45 or start at age 50, but the most lives can be saved when we start at age 40. And so you start 40 and you do it once a year annually. We usually supplement with at least an ultrasound to increase the sensitivity of the mammogram. And in certain cases, when the patient's deemed high risk or has very dense breast tissue, we will also add on a breast MRI.
I have one question for Dr. Kalman, but before I ask that, one family history question. Sister died of pancreatic cancer under 50, mother with breast cancer in late 50s. Is genetic testing important to me? Nicole?
Yes.
Yes, agreed. Absolutely. Dr. Kalman, a question about COVID. Will there be a vaccine?
There's definitely going to be a vaccine. I mean, if you read in the lay press, there are many companies vying, and there'll probably be several. Some of the vaccines, most of the vaccines I've read about require two doses, two doses 28 days apart. One company is working on a single dose. Most of the drugs require super low refrigeration, low temperatures, which is going to affect, in fact, one of the big distributors in the country, McKesson, is building a refrigerator farm outside of Louisville, Kentucky, just to house all the vaccines. So it takes a lot of, not only there will be a vaccine, but there's a lot of logistics to get the vaccine distributed and prioritization that has to happen. But there definitely will be a vaccine. I think that with all the political pressure and all that's happened, that vaccine is going to be safe. They're not going to release a vaccine early before there's shown safety indicators. But again, it's going to take time. It's going to take well into, I believe, the middle of next year before a vast number are vaccinated. And in the meantime, we have to do all the other things that are important: social distancing and masking. And I just was listening on NPR this morning, dramatically increasing the number of point of care testing with just saliva is coming in a couple of months. And that's what's happening with the NBA and other things. So you imagine if every school and every medical facility could test everyone every day, or nearly so, that would obviously give people a lot of solace and peace of mind going and doing things that they need to do.
And could you share just maybe 30 seconds or a minute about how the cancer world, how one of our physicians who's bone marrow transplant specialist got involved in treating COVID patients?
Well, it turns out that transplanters, especially people who do allogeneic transplants, that's transplants from a donor bone marrow to a patient, as opposed to autologous transplants where the patient's their own donor. These doctors are specialists in viruses, because viruses can be very deadly in this allogeneic population. So Dr. Gunter Kona, who we recruited from Memorial Sloan Kettering, who's our chief of stem cell transplantation and benign hematology, has been very involved in several therapeutics over the last number of months, and is a principal investigator on a number of trials. And you may have seen that wonderful story about one of our workers here at MCI, a young woman in her 30s with several children who worked in the radiation oncology division, who became gravely ill. And Dr. Cohen had a clinical trial, and that patient was treated while she was on a respirator and very ill, and recovered within days and left the hospital within a few weeks and is now back and working. So yes, some of our investigators, one of our chief of radiation oncology has a very unique trial that involves a single dose of radiation to the chest, which has been proven in India and other places to take people who are very ill and have them recover from COVID. So our folks are very actively engaged, even though they're cancer doctors. Some have been very actively engaged in treating COVID.
Dr. Mehta is actually on the call. If we forgot to mention to answer any questions about radiation oncology that participants may have. If anyone has questions about radiation therapy in general for breast and ovarian cancer or for COVID. There's a couple quick questions I can answer. Does aluminum and deodorant contribute to breast cancer? No. There are a lot of myths when it comes to breast cancer risk. Aluminum and deodorant is not one of the risk factors for breast cancer. Neither is underwire bras or eating dairy. The biggest risk factor is being a woman and aging. And the best thing that you can do to decrease your risk of developing breast cancer that could potentially kill you is by getting screened to catch something early before it can progress. And then in a woman who had a bilateral nipple-sparing mastectomy with 3 positive nodes, is annual MRI screening appropriate? After someone undergoes mastectomy, if it's truly a complete mastectomy, we usually do not do routine imaging for screening. A clinical breast exam alone is usually adequate. That being said, if someone has a clinical finding like a palpable lump that develops and it's new, then we do imaging. We may start with an ultrasound, and MRI may be indicated. Sometimes MRIs are done to look at the integrity of the breast implants and make sure they're not ruptured. But I would advise seeing a breast specialist if there's any concern regarding that. And Nick, there was a question about you, with pap smears.
The question is it true that women after 60 do not need a pap smear? Remember, a pap smear is done for cervical or vaginal cancer screening. The new guidelines are if you're HPV negative. So if the pap smear was done and there's no HPV and you're over 60, then you do not need an annual pap smear. However, an annual pelvic examination is still very important. So don't equate no pap smear with not seeing your gynecologist. You still are recommended to see your gynecologist annually. So I think that might be it for questions. I want to thank Dr. Kalman. Did you want to?
I just want to say that I thank Nicole for touting our wonderful genetic counseling service. We're also one of the few institutions that have a medical geneticist, someone boarded in medical genetics. So after the counselor takes your history and the blood or saliva is tested, we then will meet with a medical geneticist who will go over all the recommendations and all the implications and make recommendations both directly to you and direct you to other specialists. So we're very happy that we have that service and we developed it, and we hope that the community will take advantage of it. Thank you.
I think there's one last question pertaining to actually breast and ovarian issues. This is a patient who says that she was diagnosed with breast cancer and had a lumpectomy and radiation, is now taking tamoxifen. Tamoxifen is a medication that we give to many patients with breast cancer to block the female hormone estrogen. And she then developed a ovarian cyst rupture and is worried about the risks of taking tamoxifen. Any intervention or medication that a patient is given for the treatment of their cancer can have potential side effects. Tamoxifen is interesting because some of the potential side effects involve GYN issues. Most concerning is that there's a small increased risk of endometrial cancer while on tamoxifen in postmenopausal women only. In terms of risk of ovarian issues, Nick can talk about that, but there are some women that can develop ovarian cysts while on tamoxifen. Nick, do you want to take that?
Yeah, I think it's probably unrelated to the tamoxifen, but we do end up co-managing patients who have a history of breast cancer and kind of talking through some of the potential side effects of treatment on the uterus or ovaries. The cyst rupture, probably unrelated, but we do kind of tend to monitor the ovarian activity and whether or not, hormonal production is important for that person. So if you have any further questions, please let us know. We work very closely with our breast team and following patients who have non-gynecologic cancers but have a history of breast cancer, and we're happy to follow together.
Great.
I think that's the last question.
Thank you, everyone.
So we have the Rock and Run this weekend. I want to put a plug in for that. It's going to be virtual. We have Team Ovary and Team Breast. Star, you're going to run or rock?
We may do both. Because it's virtual, you have the ability to maybe run on Saturday or bike or rollerblade or whatever your preference is, 5K, and then we can do rocking on Sunday. So that is one of the benefits of a virtual event. You can participate in all aspects of it. And I have my mask. So if you haven't gotten yours yet, this is a cool little mask that they gave out. So a little plug for Rock and Run. They developed an awesome little tie-dye pink and teal mask. So sport it. And advertise the event. They have a lot of participants and it's a great community event, and it's something that can bring us all together while we can't physically be together. So I look forward to participating this weekend. Hopefully I'll see a lot of my patients, at least through their posts and social media, participating as well.
Thank you all.
Thank you for everyone, to everyone who tuned in. Georgette from American Cancer Society, thank you.